Welcome to Health System CIO's interview with Dr. Ram Chadalavada, Vice Chair of Radiology Informatics at the University of Cincinnati and UC Health. I'm Anthony Guerra, founder and editor-in-chief. Dr. Chadalavada, thanks for joining me.
Anthony, thank you so much for having me. It's a privilege and a great opportunity to speak with you and colleagues everywhere.
Excellent. Thank you very much. All right, let's start off. You want to tell me a little bit about your organization and your role or your roles?
Yeah, absolutely. Ram Chadalavada, I think just having some context clinically, what I do is also very relevant to this conversation. I'm a vascular interventional radiologist. I serve as a vice chair of radiology and informatics. At an institutional level, I've worked very closely with Dr. Frank Fernandez, who's the Chief Medical Information Officer, the CMIO, who also reports to Dr. Umberto Tacchinardi, who is our Chief Health Digital Officer. Not only works with the hospital system, but also from the University of Cincinnati and UC Health, where I practice clinical medicine, but also serve in an informatics role.
All right, very good. So you're with both University of Cincinnati and UC Health.
That's correct. The hospital system is recognized as UC Health. The academic entity is University of Cincinnati. We're a robust academic center with residency fellowship programs in various specialties at College of Medicine, training medical students, and biomedical engineering from the undergraduate level. So this is kind of a very robust ecosystem here.
All right, excellent. So we're going to talk about enterprise imaging today, as sort of generally what I'm hearing is more of a journey and a direction rather than a final end state. For example, if you're implementing Epic, that's sort of got some real milestones in it where you're done, like almost, or you've got stages, but there's definitely hard milestones. Enterprise imaging seems to be more of a many different ways people are trying to get there, almost different strategies, different goals for the journey, but there probably are some commonalities there on what people are trying to achieve. So let's start off by, if you want to give me your vision or definition or thought about what we mean when we say enterprise imaging as opposed to maybe where we've come from.
Yeah, I take a very kind of simplistic approach to enterprise imaging. Basically, radiology is one of the biggest gorillas related to enterprise imaging or imaging. But the way I see it is more of a data. So it's our ability to consolidate imaging data from various sources across the health system and any of the various entities that practice utilizing imaging. And you name it, right? We have radiology, which is a big gorilla, but we have cardiology, pathology, dermatology, ophthalmology, gastroenterology. So various sectors throughout the health system play an important role. And to me, if there is a picture involved, whether it includes light pictures or direct visualization pictures or X-ray based pictures, um, those are all, to me, I see them as the same when it comes to imaging data and how to organize those. And I think this is really important because the enterprise imaging model, there's two primary entities that play a role into this, right? So you have the clinical faculty, the staff, and then you have the patients. So having the seamless integration of imaging data across the various different departments, whether it's radiology, pathology, is just better for us to communicate as clinicians and coordinate care. Because think of the situation of a multidisciplinary conference where you have the oncologist, the radiologist, the pathologist all there. And in order for them to work, you also just need to work together in the imaging infrastructure as well. And that same thing, I think, applies to patients. Patients want to be able to integrate through their imaging because they might have a GI scope where they can see the visualization of their endoscopy, and then that leads to a pathologist evaluating a specimen that they may have gotten a biopsy of. So it's improved patient care, There's efficiencies in workflow from day to day, but also from a system level, and then just overall better utilization of our resources.
All right, very good. So, I mean, how do we move forward in this? You mentioned all the different ologies. Um, and I guess we can use the term PACS for the system that holds the images. That the image gets spits out by the modality, the actual machine. It goes into a PACS system, at least on an interim. That's sort of step one. At least again, I've got sort of a high level. I'm trying to learn this stuff, high level understanding,
Yeah.
but it's like from the modality to the PACS. Now, you talked about the different ologies, right? So
Yeah.
you could have, and I know you said you have not grown through acquisition, but some places have. But even still, there could be different pack systems within an ology, right?
Yep.
So,
Absolutely.
do we want to do we think of this as okay? Step one, let's try and standardize within the ologies on one pack. So instead of having three in radiology and four in cardiology and two in dermatology or whatever the case may be, let's see if we can shrink that down so we standardize more per ology. And then maybe after we standardize on one per ology, what's the next level of bringing images together? Well, some people say it's a VNA,
Yeah.
right? And then if we get everything into a VNA, ultimately, what do we want to do? We want to make sure the VNA is integrated with the EMR so the patients can get everything, or different clinicians can. That's my high level kind of thought here or understanding on some of the ways to go forward.
Yeah.
Tell me if that makes any sense or what your thoughts are.
Yeah, no, Anthony, I think you're right on. I think there is a lot of, like you said, while we haven't undergone acquisitions, but there's a lot of transitions happening in the healthcare ecosystem from city to city, small town to small town, and just regionally as well. Whether it's Southeast United States, the Midwest, there's a lot of transitions happening within healthcare, and I think these affect the day to day ologies and the day-to-day operations. So, for example, I think one of the key things, your transition of having the different variants, paxes, the different departments, I think it starts with representation. Um, First of all, just knowing who the folks are. Typically, departments of radiology have identified informatics persons, and they're kind of the leaders in most healthcare systems. I think they've been a decade ahead of most of the other departments in identifying an individual. I think once you have a not necessarily a spokesperson, but like a doer, a actionable person, somebody who has the background knowledge in this armamentarium, I think is really important. For example, in our institution, I represent radiology, and Dr. Mary Mahoney was very early on in identifying a vice chair of informatics. I've been this is my 10th year at University of Cincinnati. I've been functioning this role, though my titles have probably changed due to funding and other reasons, but I've been serving the same role under her leadership for 10 years. And I think other departments have been trying to work and recognize that. And so I think at a chair level, our cardiologists are recognizing a need for an informatics person to go to. I actually help supplement that quite a bit because of how our management system is organized on the IT side. Our pathologists, we've actually recruited an informatics person in our department of pathology. So identifying those individuals, I think, is really important. So I'm kind of a people first person, and just kind of knowing who they are. And that helps develop, currency and helps identify some leadership within those silos so they can come together. And then I think you have to, in some ways, go to the organization. In our case, we do that. We want to implement a organization-wide imaging strategy related to the ologies and related to these other components. So I think that's something that we think about and we organize around, and so that we can make those kind of fundamental transitions and decisions.
Right. So that's almost a step one in your mind is make sure you have somebody dedicated to the informatics in each ology to be in there embedded, thinking about image sharing and facilitating that. That's sort of a step one, and then you can go from there. Is that correct?
Yeah, I think so. I think, first of all, it gives you a quick, yeah, identifying the individual, and then depending on how these individuals function, I'm in a very collaborative state of mind and invited kind of role. I like meeting with our pathologist who has recently joined in the informatics. Actually, our chairs helped us introduce each other, which is great. I'm looking forward to meeting, the dermatology person that's identified in this role and the ophthalmology person in this role. So I think this also gives us the opportunity to say, hey, there's already collaboration happening between radiology and pathology. And I think these are examples that you can cite to IT leadership or hospital administration. And I know I'm using these terms just very generically, but there would be individuals, like in my case, the Frank Fernandez, right? He's the CMIO. He would be persons that I would introduce to, engage with, and have maybe a quarterly meeting with, as our teams work together. In our institution, we're working on reorganizing our informatics teams, just kind of an evolution of things. Before it was very EMR centric, but
Uh,
we realize it needs to be more at different institute levels. We need to be at an outpatient level, inpatient level. So having, different partners in each of those things. And I think just as importantly, the other stakeholders I'll bring in, Anthony, is I think the vendor partners are also really important to this. And some of us have really good and ongoing relationships with them. They have examples from other institutions that they can bring, other successful projects, and maybe even projects that didn't go as smoothly that we can also learn from.
you mentioned identifying informatics folks. Do you feel like um, it's best to create the position and then hire for it? Or do you think it works well when someone who's currently practicing as a clinician or in some fashion in the department is identified as either having an interest in informatics or whatnot? And then that used because you talked about identifying the person. It's almost like they're there and okay, it's going to be Sue because she's really into this stuff. And maybe
Sure.
let's get her trained up and stuff and see if she wants to go down this career track.
Yeah. No, Anthony, this is a great question. So, I think that it's a two-pronged approach. And I'll tell you this because I think it kind of becomes on your resources, your location, what you have access to. So I'll tell you a little bit about my pathway. I trained at University of Pennsylvania, or HUP, Penn Radiology. I was a diagnostic resident there. I also did my interventional radiology fellowship there. But as an integrated program in my fourth year, I also did an informatics fellowship under tutelage of Dr. Tessa Cook. At that time, Dr. Kurt Langlotz was there as well, and Dr. Mitch Schnall. Informatics was an important part of our ecosystem at Penn, and so I feel like I was at the right place, the right time, and we that program. I'm the first graduates of that fellowship program, and since then there've been a number of folks who've infiltrated across the country, whether it's at Cleveland Clinic, some of our private practice programs, Emory, you name it, they're everywhere. And I think having individuals who've been subspecialized, trained, certified, SIP certified, SIM and ABBI provide amazing resources. So people who kind of had the right mentorship and who've been shown the pathway and opportunities, I think are excellent resources. But there are not that many of them. There's a supply and demand. I think demand is high, supply is somewhat, limited. If you have the opportunity to recruit such an individual, not only do they complement a clinical need you might have, but even if your clinical need may not be high, but that informatics need is there, I think it's a good strategy to secure those resources into your department, into your institution. I say this in the most humble way, but I think, my colleagues and peers will say there are not that many ROMs that are in interventional radiology that are patient facing, that are integrated with our referring physicians all across the institutional and also in the informatics system. So you kind of understand the dynamics of the providers, also understand the dynamics of our patients. So you don't have to be only an interventional radiologist who does informatics. There are other great clinical folks who also do informatics. So I think having that kind of training and experiences is huge. However, if you don't have that, I think um, first, it starts with the local leadership, recognizing the importance and the need for having this. I think most radiology chairs, I had the privilege of attending SCAR, which is the Society of Radiology Chairs Association. It's a wonderful group of amazingly talented, gifted folks who recognize this is an area that probably needs informatics in their specialty. And I can tell you, a number of departments need it, want it. They are recruiting hard in this space, but sometimes they have to identify folks locally who may have showed an early interest. I don't think it's one of those things where you just get appointed and you do. It has to come with some infrastructure. Understanding probably just starts with reading some of the basic texts in informatics, just understanding your local ecosystem. When did we move to the EMR? Who were we? What did we have? When I got here in 2015, even though I had this formal training, I had a lot to learn about this environment. And so if you have somebody that's vested and understands it and is willing to put in the time and the resource and the effort, I think absolutely it comes to part at an individual level, department level, and an institutional level to groom and grow. I personally think it's a 5-year process to take somebody that hasn't had some of the formal mechanisms or prior experiences to groom into that potential role.
All right, very good. One of the biggest issues in this area seems to be is that we talked about having a number of different packs in a particular ology. Um, Ultimately, there's sort of two opinions that I've encountered. One is let people continue to use what they've been using because they like it very much, and it's very hard to get people to give these things up. So let them use what they're using. Don't worry about trying to sunset different pack systems and integrate on the back end. That's sort of a extremely user-friendly approach, but it may be more onerous on the back end, the technologies of it, and to keep all those integrations going. And the other end is let's almost like an EMR approach, which is let's consolidate on one platform. Let's get everybody moved over, and then we have nothing to worry about. It may be a nightmare, make everyone miserable, get people want to quit. But once we do it, everyone's happy and we're beautiful and life goes on.
Sure.
You're a user, you use this stuff, right? So you know how, I guess, connected you can get to a particular pack system, the comfort level. I mean, you're doing clinical things here. You're viewing him. You want a level of comfort here. So, what are your thoughts around that dynamic? And ultimately, I guess if you do have to tell a particular set of radiologists that they're going to be moving off a system they're using, do you have any thoughts on how to do that successfully and get them to buy into that kind of change?
Yeah, Anthony, a great question. I think one of the caveats we mentioned when I started is that uh, I have not personally been involved in any transition at the health system for UC Health because we haven't done any mergers and acquisitions. But just as I started in 2015, our two hospitals, Westchester Hospital and UCMC, came together. They kind of functioned as independent hospitals. So I kind of saw a flavor of it just shortly after I saw it. But I'm just giving that caveat. But no, this is a great question that I want to address. There's a technical and informatics component to this, and then there's a people component to this. And so most institutions and a lot of departments, just see this as a technical change or IT change. And I think this is where having the clinical background of somebody like me in my clinical role is really important to facilitate and to understand the process. So if I've observed through several of these transitions at regional hospitals and nationwide, and also several of my colleagues who've acquired different practices in private practice. So I keep a pulse throughout the country. I think it kind of just understands knowing where you are as an institution in the march of these acquisitions and transitions. Are you in kind of the early phase? More's coming. And what kind of research and infrastructure have we done? And what kind of research and infrastructure input have we sought from our practicing radiologists. Like what's working, what's not, what have we made things. So there's some kind of last mile things that you have to do, whether you're going to stick with one mechanism or other. So for example, if we're going to let people keep the different systems, you have to first understand the people side of things. All right. Are there people merging from a different practice that are joining your practice? So you might have to include a transition period for that to come. Do you have a crossover or cross coverage of people being assigned to different areas and different hospital systems? So they're using different packs. And maybe is there an opportunity to see the best of that versus the best of this or the worst of each? And depending on where you are in the march of transitions and acquisitions, you might be taking that approach where you're thinking about the two different systems. Or if it's a more of a hostile situation, you might need to be the person that's softening those transitions. So oftentimes the informatics and IT can be the early integrators, interactors of those. So I think there's value, but as a health system or a practice has marched on, evolved, and they're more established, or they've done the infrastructure, or they've done it before and they've implemented it and they've had successes. They know the value of following in a stepwise checklist manifestation of do this first, do that first. Let's also think about the peoples, how we organize and assign them to their assignments. Do we have a buddy system? Do we have a paired system? Is there clinical intensity at one location paired with their technical utilization? Is there EMRs? Is there logins? So I think it is possible to do either, but I
Hmm.
think more and more infrastructures and institutions are kind of simplifying their
Yeah.
situations so that they can merge and bring people on. But I think it's so important if you go with the latter, which is you have a system, we want to bring everybody onto this. This is that we implement and understand the people's process, the training process. Do we have enough staff to be able to train and onboard? So all those surrounding infrastructure
Yeah.
needs need to be understood.
Right. So if we go with the we're all coming onto a consolidated system and we acquire a new radiology practice and it's part of the deal that they're going to come onto your system. I think what you're saying is you better know what you're doing with that
Yeah.
transition, and experience helps. And I did interview um, one institution where, yes, this was their policy. Everybody comes on to their platform. And the sentiment was expressed that yeah, it was hard at the beginning, but we've done so many now that it's smooth,
Yeah.
right? So we learned the process, and as you said, we've got our checklist. We know how to do this, but it's probably not easy to learn that. Those are learnings that come painfully over time.
Yeah, absolutely. And also just as important, like, the is there a person that's involved in the operations? Is there somebody, I recently met a vice chair of communications in one of the departments in the Midwest at University of Wisconsin. And one of their, they're a champion, a leader for being a communicator within their department, especially as new members come in or new people, faculty are acquired or hired. So they're just there's the people side of things that I stress quite a bit on.
Yeah, it makes me think of governance here. I mean,
Yeah.
how important do you think governance is in all these things you're looking at, all these things you're trying to achieve, these directional things. We want to move in this direction. Big picture stuff and then smaller department level stuff, things tracks going on simultaneously. Governance, from everything I hear and everybody I talk to, is just so important to have the right people and the right committees to help you, enable you to make the best decisions possible. What are your thoughts?
Yeah, governance and ownership are kind of aligned with me for me because I think governance helps identify who the stakeholders are and who's owning certain aspects and how do we all collaborate.
Hmm.
Because at the end of the day, governance to me is the collaboration, the fundamental reason is collaboration between the imaging focused clinicians and the enterprise level IT executives. All right. And I think it's really important. I think it's also making sure got part of governance is all the right people invited. It's okay to maybe invite the wrong folks, but you cannot miss
Mm.
the must-haves at that part. So that's one of the key things. It's kind of like having a party, but you forgot to, it can kind of blacklist you a little bit if you don't have all the key stakeholders identified. So again, identifying all the clinicians and then the enterprise level IT executives. So the creation of like these governance structures, I think is really important because it allows shared ownership of this so-called enterprise imaging initiative. Like who's all involved? How are we going to get there? This can be anywhere from like committees that include both the clinicians and IT folks. Um, so to develop the strategy, but I think you also need them on the when you're in the heart of it, but also even on the back end, right? So let's say you made this governance plan, you tried to implement it. This same group of people and system is also going to be there for your troubleshooting and also like future progress and also being able to see to the future. So I think it's a really really important system and need to have.
This is a good one. I think it just came to mind. You mentioned the word collaborate a few times. We talked about governance. It's important to get the key people involved. We've also know that in especially academic health systems, um, things can move slowly. When what you want consensus, you want everyone to agree, you want everyone to be happy and feel heard. How do we make sure we keep moving things forward and that we're not constantly tabling things to the next meeting? Is that a problem? I mean, that's a problem in academic health centers, right? It can be a problem that things can sometimes not move forward towards action at the pace you want. Tell me if I'm wrong.
No, Anthony, I think the so-called the stalled effect or the let's revisit this.
Yeah.
I think this happens in lots of domains. I don't think it's exclusive to academic
No.
medicine, so I'll look out for us in that way. But I do know this happens in many different industries, many different arenas. But yes, it definitely also happens in academic medicine. But actually, I tend to focus on some of the background infrastructure on leadership. For me,
Uh,
leadership is very important in this in this infrastructure and their leadership, their organization, their vision. I am the type of person who looks to our leaders to know, have a good depth and breadth, have a checklist, have timelines that are in place, and then they're the ones that help lead. And a lot of the work has to happen not at the meeting, but it's kind of, if it is a meeting that's happening, it's got to be a work meeting with decisions and
mhm,
actionable items in between.
mhm,
And I can tell you this from my own local experiences, whether it's on the clinical side or whether it's on the informatics side. I tend to follow the same policies and mechanisms, and I shouldn't say policies, but same working um, patterns. We're gonna here are the objectives. We declare in email the night before I send out. Here are the things that we're trying to accomplish. We hope that you've made some progress since the last meeting, and then here's what we're gonna address. Uh, and in those meetings, we try to go through a checklist. Time management is very important because sometimes things take much longer than anticipated, or they actually deserve it. And so being organized in that fashion and then closing the loop and kind of sometimes being a concluder, be like, okay, this is where we stand at this. Why? Well, it could be a 9 to 1, but it might be something we need all 10 people to be on board.
uh,
Let's investigate, find out what it is. Okay, well, are they not at the meetings? And all those kind of things are really good. I think leadership is really important to me. And like also the minutes that follow. For me, I'm not the type of person that sends out the minutes just before the next meeting. It's actually the minutes should follow immediately the current meeting that happened so that people know what the summary is. If they have any discrepancy as to what's happening there and what were the actionable items, who was doing what, I think needs to be uh, dictated. So I guess what I was going to say is these kind of things can happen anywhere, but I
Yeah.
think it fundamentally comes down to the leadership, the culture, and kind of the expected timelines that should be set out.
Yeah, and holding people accountable, right?
Yeah, absolutely.
All right, we're just about out of time. I just want to ask you a final question. As I said, most of our readers are going to be the CIOs and the CMIOs, and I want to help them with these interviews, understanding, if imaging. It's certainly probably on the radar of all the CMIOs, but for the CIOs that don't have imaging sort of front and center in their radar, I just want to get help them to be thinking along certain lines. I want to um, just educate them about this space. Maybe they'll initiate some conversations with different department level folks to find out what's going on. Maybe they've been approached by department level clinicians about different things they would like to see happening along imaging lines for sharing. So, what would your best piece of advice be to the CIOs and the CMIOs? Your best piece of advice on how they need to think about working with the departments around imaging.
Yeah. Um, People first is one of the things that I always like focus on. I think what I would tell our CIO peers and colleagues is there's just a need for leadership, effective, management or change management, and also the people part of this is focus on the collaboration between the clinical teams and include all the key stakeholder departments. Make sure no one's left out, and then IT to successfully implement enterprise imaging aspects or the infrastructure. Because it's the guiding principle. So if our CIOs, I would presume one of the main goals is to enhance the patient care. They want to make sure the operations are streamlined, that is smooth. It's also accounting for the retrospect or the history of that institution, but also forward thinking, setting up for success, and then just leveraging the technologies we have currently or that are coming to make sure we improve our patient experiences, our clinical outcomes, and address the two key parties here, the clinical teams, obviously the IT teams, but also ultimately the patients. So I think if that is the perspective or the mindset,
Yeah.
I think they are off on their a great trajectory.
And this absolutely should be on their radar, right? They should be thinking about imaging. Would you say
Absolutely.
that? Yeah.
Yeah. Imaging is growing in utilization. It's growing, obviously, it has a huge contribution from economics to the institution. It's also important for patient care, patient decisions. Patients, I rarely have met a patient that does not have an imaging infrastructure or imaging tests in their jacket.
Yeah.
So it is an important part of what they are, no matter what specialty it is. And imaging is very centric to a pillar that they function around.
Excellent, Dr. Chadalavada. I really appreciate your time today, and I hope you have a great day. Thank you.
Thank you, Anthony. I had a wonderful time speaking with you, and this is a very important topic and near and dear to me. So thank you for this opportunity.
Take care.